Now, when should we think of surgery? If there's a large goiter or somebody who's below 5 years and you can't do a radioactive iodine, the preparation I discussed earlier, you would be thinking of anti-thyroid drugs along with iodide, which will help you out. And the protocol basically is using a high volume expert surgeon because children have a higher risk of complication, and a near total thyroidectomy is recommended. Children have got more complications, especially for hypocalcemia. So you have to consider calcitriol for some time. So we'll now invite Dr. Naveen, who will talk about the surgical aspect of management.
Good afternoon. So the most of the points have already been dealt with, and it will be a rapid revision of whatever been discussed before. So let's move on to the basic indication. So whenever a patient presents with thyrotoxicosis, when do we have to consider surgery and whom we have to consider? So in case if it is a proven Graves' disease, then we need to consider in children in less than 5 years of age. If case of a large goiter, if it is more than 80 gram, or in case if it is causing obstructive symptoms, and in case if you have tried anti-thyroid drugs, and if there is no response, or if there is multiple relapses following anti-thyroid drugs, or in case if you are given radioactive evaluation in case and there is no response, or in case if there is a lot of relapses, and in case of severe or persistent side effects, as already mentioned, the form of hepatotoxicity or severe agranulocytosis or severe idiosyncratic reaction in the form of Stevens-Johnson syndrome, then we need to consider the patient of Graves' disease for surgery. And in case if the thyrotoxicosis is due to a solitary nodule, then we need to directly emphasize the patient on surgery. And also in case of multinodular goiters, which is quite rare in children, but in case if we rarely see them, then we need to ideally send the patient for surgery. So regarding the type of surgery, so it is not subtotal, I'm sorry, it is basically near total thyroidectomy. And it is, there are two basic modalities, which is basically thyroidectomy or near total thyroidectomy. And it is suggested for patients with Graves' disease and toxic multinodular goiter. And in a lot of studies, it has proven that doing a complete thyroidectomy is more beneficial and has very less side effects as compared to that of a near total thyroidectomy. And lobectomy can be considered in case if there is a functioning solitary nodule. And how to prepare the patient for surgery? So first and foremost thing is that when you identify a case of thyrotoxicosis, there is no point in sending the patient directly to surgery, even if it is a definite indication for surgery. So first of all, we need to bring the patient to euthyroid state. So basically, we need to start methimazole, and has to be continued until the day of surgery. And patient has to be sent to surgeons only in the thyroid function has been stabilized. And it is also emphasized, which already discussed, that we need to start on oral iodide 10 days or 2 weeks prior to the surgery. This is basically done to reduce the vascularity and decrease the risk of profuse hemorrhage. And in case if there is severe or persistent side effects, and in case we are not able to give anti-thyroid drugs, so in such a cases, we need to it is very difficult to normalize the thyroid function in such cases. So in case if you are not able to normalize thyroid function, there is an increased risk of developing thyroid storms. So in case where there is a contraindication to anti-thyroid drugs, then we can give oral iodide therapy, which is supplemented by beta blockers to reduce the tachycardia and vascularity, which basically will decrease the complication of bleeding, and give steroids, which will decrease the complication of thyroid storm. And most important thing is that the most common complication which is encountered around 10 to 50% of the cases of thyroidectomy is the transient and permanent hypoglycemia. So this is basically prevented by supplementing vitamin D and calcium, and this has to be started 1 month prior to the surgery. And before surgery, we need to replete the vitamin D and calcium levels. And it is also found out that supplementing patient of activated form of calcitriol 3 days prior to surgery has resulted in decreased level of incidence of hypocalcemia.
You give it for 3 days prior and 2 days subsequent.
Yes, sir. And following the surgery. And the most important thing is that it has to be done by a high volume thyroid surgeons who actually does more than 30 surgeries per year, because the risk of complication is more higher in pediatric age group as compared to adult. So it is very important to refer this patient to high volume thyroid surgeons. And with regards to the complications, as I already mentioned, the most common complication, which is seen in around 10 to 50% of the patients following the surgery, is the hypocalcemia. It can be either transient or permanent. It is basically because of the injury to the parathyroid glands. It is basically the hypoparathyroidism which is causing hypocalcemia. So in case if the hypocalcemia is persistent for more than 6 months, then we call it to be permanent. And regarding the management of hypocalcemia following the surgery, I'll be discussing in detail in the subsequent slides. And with the next most important complication, which we often see, is the recurrent laryngeal nerve palsy, which is often identified on the clinically by the change in voice, hoarseness of voice. And this also could be a transient phenomenon. In case if it is persistent more than 6 months, then it can cause permanent recurrent nerve palsy. And it is diagnosed only by means of laryngoscopy. So it is ideal to do a laryngoscopy following a case of thyroidectomy done. And the other less complication, which are often noticed in children, are infection, hemorrhage, keloid development. And this is even more lesser in case if the surgery is being done by a high volume thyroid surgeon. And a lot of have already been discussed with thyroid storms regarding the preparing the patient for surgery and regarding the management of thyroid storm. So this was the paper which was basically published in the European Thyroid Journal, which basically discussed the most common complication being the transient and permanent hypocalcemia, which is seen in around 10 to 50% of the cases. And it is also more common even with experienced high volume thyroid surgeons. So in case of how to approach a patient with hypocalcemia. So as already mentioned, we need to replete the vitamin D and the calcium levels right 1 month before the surgery, and we need to have them in the normal levels before going for the surgery. And it is also important to supplement with calcitriol 3 days prior to surgery with a dose of 0.025 microgram per kg and with a maximum dose of 2 microgram. So once the surgery has been done, so immediately following the thyroidectomy, we need to get a PTH level done 25 minutes post the thyroidectomy. Once the PTH level is more than 16, then this is a very less risk of developing hypocalcemia. Then we need to do the calcium level. In case if the calcium levels are more than 8.5, then we need to repeat only in case if there is symptoms of hypocalcemia. And in case if there are no symptoms and if the calcium level is normal, then we can discharge the patient after no other complications are present. In case if the PTH level is less than 16 at 25 minutes following the surgery, then we need to immediately start the patient on calcium carbonate and calcitriol. This is basically, we need to start IV, and we need to shift to the oral basis on the following days of surgery. In case if the symptoms are present, in case if the symptoms are severe, the form of peri or anesthesia, then we need to immediately start on IV infusion, and we need to monitor more rapidly, more frequently within every 3 to 6 hours. And once the calcium level normalizes, then we can shift the patient to oral calcium supplements, and we need to discharge the patient when 3 continuous levels of calcium are normal. And apart from this complication of hypocalcemia, we also need to ensure that there's no bleeding, all the drains are removed. And apart from that, we also need to ensure that the patient is not having fever post-surgery, and the patient is maintaining hydration and is able to accept fluids orally. So following this,
PTH is very, very important. And if your PTH levels are normal and calcium is normal, that is fine. If your PTH is normal and calcium is low, it may be transient usually, you can manage it on it. But if PTH is low and calcium is severely low, that is most likely long-term. Most cases, it is because of a vascular. Because when you're putting a clamp, the blood supply of the parathyroid level is stopped. So then you get transient. But you can also have, because when you're removing the thyroid, you have got at least 2 or 3 adult patients with total thyroidectomy who come with hypoparathyroidism, which is permanent. That becomes very difficult. It's like a hypoparathyroidism because you have very high doses of calcium and calcitriol.
And the most anticipated complication following thyroidectomy is thyroxine supplementation, which has to be followed day 1 after the surgery, and it is basically based on the age group. And we need to repeat the thyroid function test only after 6 to 8 weeks because of the it takes around 6 to 8 weeks for the thyroid axis to get reset, and we need to repeat it annually. and as and when in case of symptoms of hypothyroidism.